طيب بسم الله والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه وسلم. I'd like to thank the organizing committee for inviting me. So today I'm going to be talking about challenges in starting and maintaining a research database. So no need to take any photos. If you are interested in any slides, I have a QR code at the end. Okay, you can scan it. It'll take you to a web page, put your email and phone number, and I'll send you the slides. All right? I have no conflict of interest to disclose, except I am not a hematologist. Okay, I am a surgeon. All right? Any information I mentioned about hematology, I checked it with Dr. Mansour Radwi first. Okay, this is his picture. If you have any arguments, you can have it with him. Okay, if it comes to a physical fight, one at a time, please. Okay, otherwise his kids will be very sad. All right? Okay, so why are we here? So we're here to discuss how to improve the quality of the data we collect. So in 2017, 552 publications from clinical trials were retracted because of poor data or poor analysis. Evidence has linked poor data quality to incorrect conclusions and recommendations. Okay? We will be talking about all types of databases, retrospective, prospective, and clinical trials. Okay? There's actually a technical term for database creation, so it's clinical data management, and it is the process of collecting, cleaning, and managing subject data in compliance with regulatory standards. The objective is to provide high-quality data, to keep the number of errors and missing data as low as possible, and to gather the maximum data for analysis. All right? So any database is actually formed from three different parts. One is the research question. The other is what is the available data. And the third part is who is the data collector. And where these three overlap is where you will find your database. All right? So what is the purpose of the research question? Is it to answer a genuine research question that I actually want to ask? If so, do you have flexibility in the research question? And is the administration willing to provide funding or personnel? Okay? This balloon is the beautiful prospective colorectal cancer database I was planning on starting when I came back from my fellowship. This pencil is the lack of personnel and training and administrative support. What happened when they met? Which one survived? Reality survived. Okay? So, is the research question being driven by a quality improvement project, for example, decreasing morbidity? Is administration invested in it? And again, are they going to provide funding or personnel to help collect the data? Is the research project for another reason? For example, for helping medical students graduate with a graduation project? Is it for academic promotion? Is it for obtaining a salary bonus? In this field, you're going to have more flexibility in that you're going to look at what is the data that's easily available first, and then you're going to base your research question on that. In all cases, the research question needs to be clearly articulated. Okay? So first question, and when it comes to data collection and data management, so it's made up of three steps or three components. One is data collection, the other is data cleaning and transformation, and the third is data storage. What is the available data? So the first question I have to ask myself is, where am I going to get my data from? In the example of a retrospective study, it's going to be usually your hospital electronic medical records. So how easy is it to access this data? What information can be easily extracted? What form can it be extracted in? Can it all be extracted for all a single patient in a single file? Can it be extracted as an Excel sheet? All right? You're going to have multiple areas you can look in, such as progress notes, procedure notes, operative notes. You might want to look at International Classification of Diseases, the ICD codes, but you have to keep in mind what is the quality of the ICD codes. If you, the doctor, are the one who's normally entering the ICD codes, and you know you're normally entering the wrong ICD codes, all your colleagues are going to be doing the same. And if you retrieve data based on the ICD codes, the data is going to be junk. So the database, you need, in order to create a database, you need to become intimately familiar with your hospital's electronic medical records or a physical record, if that's what you still use, because that's going to help you create your database and understand where you're going to get your medical records from. In my opinion, the single most important step in all this lecture is this. Go visit the IT department and ask them, what information can you give me easily? Okay, ask them, can you give me the consult's notes easily in a single file? Can you give me the lab values? Can you give me pathology report in a single file? If they can, this will make your life much, much, much easier. All right? Make them your best friends. All right? Example, we wanted to create a database of laparoscopic cholecystectomy patients who were getting their gallbladder removed. So what we recognize that anyone who's doing that usually has an acute cholecystitis, and those patients are getting referred to general surgery. So we asked the IT department to give us a list of all the consults in to general surgery at a specific point in time. We got an Excel file, and then what we did is we asked the Excel file, we searched the Excel file for the word cholecystitis, so we could remove the patients who were referred for hemorrhoidectomy, for colon cancer, for bowel obstruction. And we ended up with a file from 1,000 patients. We had the 50 patients who had acute cholecystitis. All right? You can consider, if you're going to do this, consider all the terms another service would use to refer a patient to you. So, for example, for sickle cell disease, they might write SCD or sickle cell SCA, sickle anemia, or sickler or sickle cell. This is obviously easier for certain pathologies than other pathologies. An example, again, you need to become familiar with your practice and what you do. For us, we know that when we perform a procedure, a surgery, when it gets booked in the OR, it's usually what's put is unfortunately not very accurate. But what happens at the end of any operating room in our institute is that the nurse comes at the end and asks me, Dr. Farsi, what did you do? And I tell her I did a hemorrhoidectomy, and she enters it in this section, the comment section, a free text section. So I go to the IT department and tell them, I want you to give me all the operative procedures were done, and then I check this section and I filter out the ones who had the procedure I wanted. Okay, so where are we going to enter the data? So there's what's called a clinical data management system. Now this is really more if you're performing a clinical trial. If you're doing a retrospective or prospective study, you don't really need this. And basically this is a very, very, very fancy Excel that is very, very, very expensive. All right? And what it happens is that it allows you to have multiple users of the system at the same time, and you can customize each one. So people have only access, example, to data entry, coding, database designing, quality checks. All right? The software can record who made a change to the database, when, and what was the change that was made. It can detect anomalies and alert you from early that there's a problem. Instead of waiting until all the data is collected and finished, and then you notice, listen, the values don't make sense. It'll tell you early, listen, this value doesn't match the other values that were placed. And it's customizable like the hospital electronic medical record system. Any hospital electronic medical record system, the physician has a different platform than the nurse, has a different platform than the administration. And this is basically what it does. It lets the data collector have different authority than the author, than the person who's reporting side effects for the medication. These are examples of the clinical data management systems that are available. Some of them are paid, some of them are free. In general, they're the same. Okay? What we will usually use, though, in real life for prospective or retrospective studies is a Google Sheet, an Excel sheet, RedCap. These depend really on how you're going to create your case report form, which we'll get to in a moment. But for example, if you want to do a study on DVT, you can, through Google Sheets, create a form where the data collector is going to enter all the data all at once. For example, they can place the patient's MRN, the date of birth. You can give multiple options or choose the single best answer based on what the research question is. You can put a free text field. Now we come to the case report form. So basically, this is the form with fields for all the data to be collected. You've identified the variables you want. You're going to create a form where everything's going to be entered. Sometimes this is an Excel sheet. Sometimes this is a form that feeds into an Excel sheet. It's designed by the trial designers. We have had people leave it to medical students to create these, and they end up with junk. Okay, so it's very important that you, the trial or designer or the author, you're the one that creates the Excel sheet and what are the correct answers or the options for each field. The data field should be clearly defined and consistent throughout. When entering data for a heterogeneous group of patients, example, different cancers, you can have different case report forms for each cancer. When it comes to the case report forms, you have two options. You can have it electronic or paper. Electronic is more secure and everything gets entered and nothing gets lost, but the disadvantage is that it's slower. Each of us knows writing is usually faster than entering something in a computer. So let's say you've decided to recruit patients in your own clinic and it's a fast-moving clinic. So then what you do, you'd create a paper case report form, make it, print 100 copies, keep it in your clinic, and when you've finished with the patient, and instead of waiting for the website to load or if the internet's available or not, or if the website is up or down, or down, then you just fill out the paper consent form, put it on the side, and then go to the next patient. But the problem is that when it gets entered from a paper form to an electronic form, mistakes can happen or the form can get lost. you need to identify and define the study variables before you create the case report form. In some cases, this is easy, for example, for lab values with known normal ranges. In other cases, it may be more difficult, like pain. So how are you going to collect data on pain? You might need to do a literature review, or you could use a surrogate. Use something instead of pain, like narcotic use, that would represent how bad someone's pain is. The design of the case report form is not based on what you want, but what you think will make the data collector's life easier, all right? Otherwise, they're going to get fed up and they're not going to fill it out properly. Keep questions and instructions as clear and concise as possible. For example, if you're collecting data on medical diseases, don't put a column, what medical disease does this patient have? Put diabetes, yes, no. Ischemic heart disease, yes, no. Chronic liver disease, yes, no. All right? Unit of measures and rounding need to be specified. Crude data should be entered. For example, weight and height, and then calculate BMI. Other examples are date of diagnosis. So put the patient's date of birth and put the date that the pathology was positive or the date they were admitted and diagnosed, and let the Excel sheet calculate that. Minimize the thinking process for the person entering the data so that mistakes are less likely to happen. You can do the same with length of stay, putting admission date and discharge date, or how many days in the ICU. This is an example of a case report form. So here they've specified for them the exact method for entering the date. I cannot stress enough how this part must be done correctly. We've had to redo data collection sheets for 600 patients because the data collectors entered the dates differently. All right? Another example is weight here, where they've put the decimal points. So they want it up to 2 decimal points, put 2 decimal points in the case report form so that people automatically put it. This is an example of a data sheet where we were collecting the length of stay for patients. So we put the date of admission and then the date of discharge, and then we had the Excel calculate the length of stay from that. Data collection should be based on closed-ended questions with fixed choices, and other as a category to be used sparingly. For example, diabetes, yes, no, unknown. Thrombus location, femoral vein, iliac vein, subclavian vein, SMV, others. Have clear instructions on what to do with missing variables during data collection. Consult with your statistician beforehand as how they think you should deal with the missing variables, because they're going to be the ones dealing with them later. This is an example of a data sheet where we're collecting the medical history of patients. So what we did, so we made everything yes, no question. Diabetes, hypertension, ischemic heart disease, heart failure, chronic liver disease, chronic kidney disease, and then one for other medical problems, so that if later in the future we wanted to look at TIAs, then all we had to do was filter this column for the TIAs instead of going back and checking if the patient had that disease or not. This is another data sheet where what we did, we wanted to look at the post-operative use of blood products. And what we did, we had the Excel sheet calculate the day of the surgery and 30 days from the surgery, and then we told the data collector, look in the system and see how many packed cells they got in between these 2 days. Count them and put the number, all right, for all different blood products. Another example was we wanted to look at ischemic heart disease after colorectal surgery. So what we did, we had the data collector look at if the patient had troponins post-op and put the highest value. And then we got a cardiologist, and instead of him going through 600 files, all we had to do was look at the elevated values with him to figure out if the patient had an MI post-op or not. Sir Ronald Fisher famously said to consult the statistician after an experiment or study is finished is often merely to ask him to conduct a post-mortem exam. He can perhaps say what the experiment died of. Okay, so very importantly, ask the statistician before you start collecting data how to collect the data. All right, it's essential, especially in designing the database and calculating the sample size and power of the study, especially when you're first starting. All right, another thing you can do is actually you can put pictures in your Excel sheet. So for example, you want to put a picture from this web page in your Excel sheet for whatever reason. Every keyboard has a print screen option. You press print screen, it'll automatically capture the picture. You won't see it, but it'll capture it. You'll go to Microsoft Paint, press paste, and then you have the picture in front of you, and you can crop out the section you want. Let's say you have the section you want now, and you want to put it in the data sheet. So you're going to paste it into the data sheet. You're going to resize it so it fits in the cell you want, and then you can get Excel to fix it. So now it's not going to move, and it'll shrink and grow with the Excel sheet that it's in. Why would you want to do that? Let's say you want to double check some of the complex information in the database. You want to check the pathology reports yourself, microscopic images, discharge summary, CT scan reports, because you're not sure the data collector is going to do a very good job of collecting it. Then you can put this picture here, and then you double check with what they put if it's correct or not. And alternatively, you can save it in a folder with the Excel sheet and put the MRN or the study ID of the patient Data should be stored and compliant with institutional requirements. So sometimes what they'll want you to do is to strip the medical record number of the patient. So what you can do, you can create a study ID for each patient and then have a separate file where the study ID matches with the MRN. And then you have that file in a different location. And if later you need to go back to the medical record numbers, you go and consult the file that you have to figure out which this study ID fits with which medical record number. Now, with regards to quality control, so definitions and terminology should be implemented consistently across clinical research. The major way to prevent data errors is to regularly educate and train data collectors throughout the clinical study. So, let's say you've created your patient case report form. So what you're going to do as the author, you will yourself do a small pilot test to ensure that all the data points can be easily found in the system and can be easily placed in the case report form. All right? Pilot test will highlight the frequency that desired variables are missing from patient records, and maybe you'll end up modifying the study because you find actually what you thought would normally be done by everybody and in the system available is not actually available, and you change the study before 3 months have passed and the data collectors come back to you with half the variables missing. Once you've done the pilot test and you're happy with this test, next you're going to get the data collectors and you're going to train them. So this is a very important step where you get them, you explain to them, you review the variables with them, the case report form, and the database where the data is entered. Some of the articles I've read have suggested that in a clinical trial, you want to keep them blind to the outcome. I disagree with that. I think it's very important to educate them why they're collecting these variables and why they're important, because it makes them more invested, and they go the extra mile to collect the data properly, instead of not understanding why they're collecting this data. Following the review with the data collectors, they should, in front of you, enter a few patients in the system so that you can see that they're actually looking at the right locations and entering the data correctly. After that, set them out and review them after 10, 15, 20 patients. Okay, get them, come back and review the data they've entered to make sure they've entered it correctly. Go to the patient file yourself and check that the values they've entered are the right values. Now, how should the data collectors be compensated? You realistically have two options. You can grant them authorship on the paper or give them money. We normally don't give both. We give them the option of either one they want. Okay? In my opinion, in our humble opinion, any prospective database without pay is not going to work. This is our experience, okay? Because authorship is not a strong enough incentive to keep them collecting data. We tend, if we're going to do a prospective database, we want somebody who's 24 hours, his sole job and his salary is dependent on him collecting the data prospectively. Okay, next question is who's collecting the data? Are they non-medical professionals? Are they medical students, interns, junior residents, specialists, consultants, yourself? Okay, so we tend to classify the data collectors into groups. So if it's a non-medical professional, we have them collect only non-medical information, the age, the address, the phone number, number of visits to the hospital, if the patient had a CT scan, yes or no. Okay, medical students, interns, and junior residents are good for continuous variables or yes or no categories. They're not good for interpreting information, and we'll get to that in the next slide. So if it's collecting hemoglobin, lymphocyte count, medical history, yes, no, in a yes, no format, they're good. If it's looking at CT scans and just figuring out if the CT scan at the end says PE or DVT, yes or no, they're good at that. If it's something where they have to interpret information, they don't have the experience and they put junk. All right? So senior residents, specialists, and consultants are good at interpretive steps. So for example, reading a pathology report, reading a molecular analysis, figuring out if the patient who came to the hospital had acute chest syndrome, figuring out if they had heart failure. This is where something, you don't have a single test which is a yes, no answer. Medical students don't tend to be able to enter this information correctly. In colorectal surgery and anastomotic leak, which is a bit of a clinical diagnosis. Ileus, which is something where they're vomiting and there's no underlying cause. And this is, again, it's a clinical picture. You as the surgeon or the physician think they have this problem. Okay? These items require experience and understanding of the treatment plan, and we tend to only give the step to a senior resident specialist or consultant. Why? The main issue is if they read the file and if something doesn't make sense, they'll dig deeper. If they read a diagnosis and then the treatment plan later on doesn't make sense, they'll automatically think, this doesn't make sense, let me go back, maybe the patient was misdiagnosed from the beginning, and they'll double check the data. An operative note in surgery. When we don't have the procedure written down and someone has to read the operative note, the medical students put junk. We have to have a surgeon read it who will be able to figure out, does this procedure make sense? Okay, example from our practice. So we had students collect the pathology of patients who were operated for, who had colon surgery. And they came back to us with a significant number who had ischemic colitis. Now, this is a very specific diagnosis, which is not very common. I was actually quite surprised. I was like, ooh, we'll get a good paper out of this. And then I double-checked the data. And what had happened is that when they read the pathology report, if the pathology report said the patient had colon cancer, and the colon cancer led to a bowel obstruction, and the bowel obstruction led to ischemia and perforation, as soon as they saw the word ischemia, they put ischemic colitis. When this was more correctly a colon cancer that had led to a focal area of ischemia. This is a separate diagnosis. So we had to redo this data. If you are unlucky and you are going to be doing the prospective database yourself, then the best advice I can give is to buy this book, Atomic Habits by James Clear. This basically teaches you how you can encourage yourself to do habits that are good for you, like exercise and eating well, okay, and stop habits that you're avoiding by increasing the immediate reward. All right, example, my colleague and I read this book, okay, and so we sat down after it and I asked him, so what do you want to change in your life after reading this book? And he said, well, listen, I'm not doing enough research. So I said, okay, listen, I know what you like to do. You like to trade stocks. Okay, so listen, from now on the rule is you do 1 hour of research, you do 1 hour of stock trading. You don't do any research, you don't get to stock trade. And the database that had been waiting for 1.5 years was finished in 3 weeks. All right, next, the quality control step. So when we get the database, after the data collectors have finished collecting data, we do several steps to check that the data is entered correctly. First, we randomly check some variables. Okay, we just choose a random patient and we check the variables ourselves. The next, we check extreme values. So when you have it as the data sheet as an Excel file, the Excel file will let you check will check the range of numbers. And as a senior clinician, you recognize that some numbers don't make sense. So for example, we had data collectors collect the preoperative albumin for patients, and they came back, one patient had a preoperative albumin of 211, which we know is not possible. Okay, so we double-checked this. So we check extreme ranges at the top and the bottom. If we can't check everything, at least we'll check the clearly abnormal ones. Okay, another thing in colorectal surgery, when we take out a piece of bowel, we have to do something with the two ends of what we've taken out. So you get an option where you give the patient a stoma, you get an option where you anastomose the 2 bowel loops, or you do both together. But these are the 3 options. There is no 4th option. You can't not do anything and just leave the patient with 2 bowel loops hanging in their abdomen. So when we had them collect data about if patients had an operation, if they had a stoma or anastomosis, then we filtered the data sheet for anybody who had no stoma and no anastomosis, and we knew this data was wrong. So we went and rechecked these variables. Okay? So you as a senior clinician will know in your field what are values that are incompatible with each other, and then you can filter the data sheet to figure out where they might have made mistakes and figure out the obvious mistakes that are there. Beware of subcontractors. Al-muqawil bil-batin. So this is where you train a group of medical students to collect the data, and then they subcontract the job to other more junior medical students who do not get the same training, and then they give you junk. Or an alternative. So this is a rumor we've heard. I don't know if this is absolutely true. So there's a medical student at another institute, not our own, who was an author on a paper, and what he did, he got students at another institute that doesn't do another research. He told them, listen, would you like to join a research study have the honor of joining a research study as a data collector? Pay me 400 riyals and you can collect data, and then you can get an acknowledgement on the paper, all right? So we clearly instruct all data collectors, you're not going to get other data collectors. It's you and nobody else. So with regards to data cleaning and transforming, so you obviously, like we said, you check data for errors, missing variables, impossible values. Errors can then be corrected, or if not possible, patients excluded. Transformation means changing the variable from one form to another. So example, you can change a continuous variable to a categorical. For example, BMI to over or underweight. Several BMIs in 1 year can be transformed to one mean BMI. Free text values can be recoded. For example, urine culture was positive for this and this organism can be changed to urine culture was positive or negative. Again, collect the data in a crude form and then modify. The Indian Journal of Surgical Oncology published an article giving their experience on creating a multi-center database when they wanted to do one for surgical oncology, and this was what they did. So they signed up for an online database, and they divided the fee among the members that were interested in joining. The individual authors can see only their data, so that nobody can look at the other guy's complications, all right? And it's password protected. they assigned or hired a coordinator who was responsible for checking the data entered and contacting the respective author when data was missing or abnormal to correct the abnormality. After contributing a certain number of patients, authors could suggest a study, which was reviewed by a scientific committee who responds within a predetermined time frame. And if they don't respond within that time frame, it's assumed that they're okay with the study. All right? The authors must finish the study within an acceptable time frame. And if they don't, then another author can take the study over so that nobody hogs all the possible research questions. Authors are free to analyze their own data, and all contributors merit authorship. Final advice, so when you're playing with the Excel or data sheet, don't delete the file, okay? And don't save it as the same one, save it with a new name. So if later down the road you make a mistake, you can go back and get the file before the mistake was entered. Don't delete columns, add new ones that are adjacent. Unify the unit of measurement for variables and unify the date entry method, and make sure this is very clear to the person entering the date. Leave a comment section for the data collector. Sometimes the data collector will find information he feels is important, but he doesn't have anywhere to enter it in the assigned columns or questions. So leave a free text column where they can put anything they think, and then you can just read it and decide if it's important or not. Meet regularly with the data collectors to ensure the data is being entered correctly, and if there are any issues, you must treat them like kittens, okay? You must be very nice. You must be open to questions, because if they're afraid of you, they're not going to come to you with the problems they face, and you're going to end up with junk data 6 months down the road. Okay, so make sure they feel they can come to you with any problems they have and ask you questions freely. Always maintain access to the data. We have had surgeons who've started studies for 6 months on paper, and then the data collector disappeared with the data. Okay, so always make sure you have access to the data. If it's a paper case report form, have them give it to you routinely. And have a written agreement with any data collector so it's clear what do they get in the end. In conclusion, before starting a database, make sure that the research question is answerable with the resources you have. Design the case report form yourself and train the personnel yourself to ensure data is entered correctly. Secure funding to pay a data collector before starting a prospective database. Have a multi-step quality control method to ensure data accuracy. Read Atomic Habits by James Clear if you really want to learn how to dedicate time to research. All right, it's not my book, just so you know, all right? Okay, these are my references. This is the QR code. I would like to thank you very much for attending. Please, anybody who wants the presentation, you can scan it. It's just going to ask you to rate the lecture. Even if you don't want the PowerPoint presentation, please just scan it and tell me what you thought, and if you thought it was junk, and if they should invite me back again, or they should tell me not to come to Riyadh again. All right. I'd like to thank Dr. Mansour Radwi and the organizing committee for inviting me. I'd like to thank Dr. Mohammed Bangish and Dr. Mahmoud Mousli, who are at my center and helped me with this lecture. This is my email and my phone number if you have any questions. If you have an experience with creating a database, I'd love to hear from you, any mistakes you made so that we can improve our own. And thank you very much.